Ever had that moment where your heart does a little flutter? Or maybe you get unexpectedly dizzy for a second?
Yeah, it can be a bit unsettling when that happens.
Totally. Well, imagine if the normal electrical conversation between the top and bottom parts of your heart just completely stopped.
Right.
Today, we're doing a deep dive into something called complete heart block. It's also known as third-degree AV block.
And it's basically when that essential electrical link gets, well, totally blocked.
So it's like the message just isn't getting through at all.
Exactly. Think of the heart like a two-story house. You've got the atria upstairs, ventricles downstairs. They need to work together, coordinate.
Makes sense.
Complete heart block. It's like the staircase is just gone, blocked off completely. The signals from upstairs, the atria, they just can't reach the ventricles downstairs.
So they just start doing their own thing independently.
Precisely. They beat to their own drums,
Right.
essentially.
Okay, so the info we're digging into today, it comes from revision notes. You know, the kind medical folks use to really get a grip on these complex conditions for exams.
Yeah, so it's pretty high-yield stuff, focused on the essentials.
Exactly. And our mission here is to break it down, make it understandable. What is complete heart block? Why does it happen? What are the key signs? And, what does it all mean? Aiming for clarity without getting bogged down.
Sounds good. So at its core, complete heart block means total electrical dissociation. If you look at an ECG, that's the heart's electrical trace.
Right, the squiggly line.
Those lines, yeah. You'd see the P waves, which show the atria contracting, doing their thing completely separate from the QRS complexes, which show the ventricles contracting.
So totally separate rhythms on the same readout.
Completely. And interestingly, there's a link sometimes with congenital complete heart block babies born with it. It can be associated with anti-Ro antibodies.
Oh, the ones you sometimes see in conditions like lupus.
That's one, yeah.
Okay, so it's not just that there's a block, but where the block happens is important too, right?
Absolutely crucial. Location matters a lot for how it presents.
How so?
Well, if the block is, say, at or just above the AV node, that's like the main electrical junction box,
Okay.
we call that a nodal block. The backup pacemaker that takes over is located higher up, often in or near the bundle of his.
And what does that look like?
On the ECG, it usually gives you narrow QRS complexes, which look a bit more normal. And the heart rate, while slow, is generally pretty reliable, maybe 45 to 60 beats per minute.
So faster than you might expect.
Relatively speaking, yes. And it can often increase a bit with exercise or if you give certain drugs like atropine. People with this type might have milder symptoms, maybe just fatigue, a bit of dizziness, some chest discomfort, or sometimes no symptoms at all.
Okay, so we could maybe think nodal and nicer symptoms.
That's a great way to remember it. Nodal, narrow, nicer.
Yeah, but there's another scenario, presumably less nice.
Yes, definitely. If the block happens lower down, below the AV node, in what we call the infranodal region, that's down in the His-Purkinje system, the specialized wiring in the ventricles.
Okay. Further down the chain.
Exactly. The backup pacemaker is located much lower, like in the bundle branches. This usually results in wide QRS complexes on the ECG and a much slower heart rate, typically less than 45 beats per minute.
And that sounds more problematic.
It generally is, yes. These patients are much more likely to be hemodynamically unstable, meaning their heart isn't pumping blood effectively enough.
Right.
And the symptoms are usually much more significant. We're talking things like syncope, fainting, confusion, real shortness of breath, sometimes severe chest pain, worsening heart failure. And unfortunately, there's a higher risk of sudden death with this type.
So for that one, maybe infra, important and impactful symptoms.
Perfect. Infra, important, impactful. It highlights the seriousness.
So this situation where the top and bottom are beating independently, that's the AV dissociation we mentioned. But the notes also mention something called capture beats. What are those? Sounds like a temporary fix.
It's quite fascinating, actually. So you have the ventricles beating away on their own escape rhythm, right?
Yeah.
But occasionally, just sometimes, an electrical impulse from the atria, from upstairs, manages to sneak through the block just for a moment.
Like it finds a gap.
Sort of. And it briefly captures the ventricles, causing them to contract earlier than expected based on their own slow rhythm. It's like a momentary return to the normal sequence.
A little blip of normal communication in the chaos.
Exactly like that. You might see these sometimes during, say, an acute heart attack, or maybe after clot-busting treatment, thrombolysis.
Okay. And do they change the management?
Well, interestingly, if a patient is otherwise stable and just has these occasional capture beats, they might not need an immediate pacemaker. The situation is monitored closely, of course.
Got it. So why does this complete block happen in the first place? What are the common culprits?
There are quite a few potential causes. Just getting older, degenerative changes in the heart's electrical wiring, that's a big one.
Wear and tear, basically.
Pretty much. Then there are various heart diseases. Coronary artery disease is common. Previous heart attacks, leaving scar tissue that blocks signals. Cardiomyopathy, where the heart muscle itself is weak or damaged.
Okay.
Certain medications can play a role too, particularly ones that slow conduction, like beta blockers or calcium channel blockers, if the dose is too high or in susceptible people.
Right.
Also, congenital heart defects from birth, inflammation of the heart muscle like myocarditis, and sometimes even inherited genetic conditions affecting the conduction system.
So it can be a mix of things, gradual changes or underlying health issues.
Exactly. It's often not just one single event.
And the fundamental issue, the pathophysiology, it's just that complete interruption of the signal.
That's the core of it, yes.
Mm-hmm.
The electrical message from the atria just cannot get through to the ventricles. It could be blocked at the AV node, a bundle of his, or further down in the bundle branches.
Total roadblock.
Total
Yeah.
roadblock. And because of that, the atria and ventricles beat independently, leading to that very slow ventricular rate and consequently reduced cardiac output. The heart just isn't pumping blood as efficiently.
Okay. So what would someone actually feel? And what might a doctor pick up on examination? What are those classic signs and symptoms?
Well, symptom-wise, fatigue is really common. Syncope, the fainting spells we mentioned, dizziness, lightheadedness. Sometimes people develop symptoms of heart failure, like getting breathless easily.
Okay.
Palpitations can happen too, feeling the heart beating unusually, and less commonly, chest pain.
And what about the signs a doctor might find?
On examination, the most obvious thing is usually a very slow but regular heart rate, typically down in the 30s or 40s, maybe up to 50 beats per minute.
So noticeably slow.
Definitely.
Yeah.
They might also notice a wide pulse pressure. That's the difference between the top and bottom blood pressure numbers.
Yeah.
And looking at the neck veins, the jugular venous pressure, or JVP, you might see something called canon A waves.
Canon waves, what are those?
It's when the atria contract forcefully. But the tricuspid valve between the right atrium and ventricle is closed because the ventricle is also contracting independently. So the blood sort of cannons back up into the neck vein.
Ah, like hitting a closed door.
Exactly. Creates a visible pulse in the neck. Another sign can be the first heart sound, S1, varying in loudness from beat to beat, again because of that lack of coordination.
Right, that makes sense. And diagnosis, how do you confirm it's definitely complete heart block? I assume the ECG is key.
Absolutely. The ECG is the cornerstone. It shows that classic complete dissociation, P waves marching along at their own rate, QRS complexes marching along at theirs, with no relationship between them.
Unmistakable, usually.
Pretty much, yes. If the block is intermittent, though, sometimes a Holter monitor is needed that's like a portable ECG worn for 24 or 48 hours, or even longer.
To catch it happening.
Exactly. An echocardiogram, an ultrasound of the heart, is also important to look at the heart structure and function, see if there's underlying disease.
And sometimes more specialized tests.
Yes, in some cases, particularly if the exact location of the block isn't clear, electrophysiological studies might be done threading catheters into the heart to map the electrical activity directly.
Okay. And you mentioned pacing.
Critically important. If someone presents with complete heart block and their unstable low blood pressure confused, very unwell, they usually need pacing straight away, either temporary external pads or a temporary wire, followed by a permanent pacemaker.
Right. Immediate action needed there. And are there other conditions that could look similar that need ruling out? What's the differential diagnosis?
Good question. You need to differentiate it from other types of heart block, like first-degree or second-degree AV block, especially Mobitz 2 second-degree block, which can also be serious.
Okay.
Also, things like bundle branch block can sometimes cause confusion, issues with the sinus node, the heart's natural pacemaker, and even certain fast heart rhythms like ventricular tachycardia or SVT can sometimes present in confusing ways, though usually they are fast, not slow.
So careful ECG interpretation is vital.
Absolutely essential.
How common is this condition? Do we know how many people in, say, the UK have complete heart block?
Precise figures for the UK aren't that easy to come by,
Yeah.
but we definitely know it's more common in older adults simply because degenerative changes are more likely.
Right.
And it's certainly more common in people who already have some form of underlying heart disease. One thing that is clear, though, is that it's the most common reason why people need a permanent pacemaker fitted.
Ah, okay. So that leads us to treatment. What's the main approach if someone is diagnosed?
For almost everyone with symptomatic complete heart block, or even asymptomatic block if it's considered high risk like the infranodal type, the primary treatment is implanting a permanent pacemaker.
The device that takes over sending the signals.
Exactly. It's a small device, usually put under the skin near the collarbone, with wires going into the heart chambers. It monitors the heart's rhythm and sends electrical pulses to make the ventricles contract at an appropriate rate. It essentially bypasses the block.
A life-changing intervention for many, I imagine.
Definitely. Beyond pacing, medications might be used to manage symptoms or treat underlying conditions like heart failure meds or blood pressure drugs. And of course, addressing the root cause, if possible, like managing coronary artery disease, is also important.
And what's the general outlook? If someone gets a pacemaker, what's the prognosis like?
Generally, with a pacemaker, the prognosis for survival related directly to the heart block itself is very good. People can live full, active lives.
That's great to hear.
However, the overall long-term outlook often depends more on the underlying reason for the heart block and the person's general heart health. If they have severe underlying cardiomyopathy, for example, that will influence their prognosis more than the block itself once it's paced.
So the pacemaker fixes the rhythm issue, but not necessarily the underlying heart condition.
Precisely. And it's worth remembering that, like any condition, complications can still occur, even with treatment.
What sort of complications are we talking about?
Well, even with pacing, sometimes people can still experience symptoms related to bradycardia if the pacing isn't perfectly optimized, though that's less common now. There's always the risk of syncope or falls, especially before diagnosis or if the pacemaker has issues.
Oh,
Having complete heart block, even when paced, can sometimes increase the risk slightly for other heart rhythm problems, or very rarely sudden cardiac arrest, though pacing significantly reduces this risk. Reduced exercise tolerance can sometimes persist, and just generally, it can impact quality of life for some individuals.
Right. It's a significant condition to manage.
It is.
Okay, so let's try and wrap this up. To summarize our deep dive into complete heart block, the absolute key takeaway is that it's a total electrical disconnect between the atria and ventricles. They beat independently.
That's the essence of it.
And where that block happens, nodal versus infranodal, really dictates how serious the symptoms are likely to be, with infranodal generally being more concerning.
Narrow and nicer versus important and impactful.
Exactly. And for those who need it, particularly if they have symptoms, a permanent pacemaker is the crucial, often life-saving treatment.
Absolutely. It really highlights the incredible complexity, but also the potential fragility of the heart's electrical system.
Yeah.
How finely balanced it all is.
That's a great point. That intricate wiring keeping everything going
Yeah.
till it doesn't.
Yeah.
Well, this has been really insightful. And for those listeners, especially anyone preparing for medical exams like the MSRA, if you want more high-yield revision material like the notes we base this on, definitely check out pastthemsra.com.
And there's also freemsra.com for some great free resources too.
Perfect. Thanks so much for joining us for this deep dive. Hope you found it useful.